I have the privilege of introducing our speakers today. First, we have Dr. Patrick Avila, who is a gastroenterologist here at UCSF, specializing in complex digestive disorders, advanced endoscopic procedures, including colonoscopy, EUS, and minimally invasive treatments of the pancreas, liver, and bile ducts. His research focuses on health policy, healthcare innovation, and eliminating disparities in access to care. He earned his medical degree from Stanford, completed his residency at Brigham and Women's, followed by fellowships in GI and advanced endoscopy here at UCSF. As fellows, we're very lucky to work with him on the biliary service and at San Francisco General Hospital as well. Thanks for joining us, Patrick.
Thank you for that kind introduction. Excited to be here. We have a lot to cover. We'll see if I get to all of it, if we have enough time to talk about sort of an interesting topic and acute pancreatitis, disconnected pancreatic duct syndrome. If not, we can maybe chat about that at a different time. I'd like to thank my partners in the interventional endoscopy service, who I learn a lot from as we manage these complex pancreatitis patients, and my mentor, Dr. Arain, who taught me a lot about pancreatitis and also shared some of the slides that I built upon. All right, so no disclosures. Acute pancreatitis is very common, greater than 330,000 annual ER visits. There's been a 12% increase since 2006, costing a lot to the healthcare system. Nearly 76% of patients are admitted. It's the third leading GI diagnosis requiring hospitalization. It's important to remember that while most patients are able to do well, there is a 2% mortality rate, and in those with necrotizing, particularly infected necrotizing pancreatitis with persistent organ failure, up to 30% mortality. So we really need to be mindful of how severe this can be for patients. Okay. The definition, as you all learn in medical school, 2 of 3 criteria: characteristic abdominal pain and/or amylase or lipase greater than 3 times above limit of normal, or and/or pancreatic inflammation by imaging, CT or MRI. Rarely we find it on EUS de novo. In terms of how we further define pancreatitis, there's mild acute pancreatitis. This is when patients meet the criteria and diagnosed for acute pancreatitis in the absence of organ failure and local or systemic complications. Moderately severe acute pancreatitis are those with transient organ failure, which resolves within 48 hours, and/or local or systemic complications without persistent organ failure. And severe acute pancreatitis are those with persistent organ failure that may involve 1 or multiple organs. In terms of the clinical features, typically patients present with severe and persistent epigastric pain, maybe radiating to the back. Sometimes it's up in the right upper quadrant or left upper quadrant. Nausea and vomiting are quite common. Dyspnea can occur if there's diaphragmatic inflammation. It is important to note, particularly those who are critically ill who develop pancreatitis in their course, or elderly patients may just have painless disease or unexplained hypotension. In terms of the physical exam, it really varies based on the severity of pancreatitis, from those with minimally tender to palpation, the epigastric area, to significant diffuse tenderness. There may be abdominal distension or hypoactive bowel sounds due to an ileus. If the etiology is biliary and there's a choledocholitis or a significant edema in the head of the pancreas, there may be jaundice or scleral icterus. Patients with severe pancreatitis may have fever, tachypnea, hypoxemia, hypotension. A couple interesting physical exam finds, which rarely seen, but you can get ecchymotic discolorization of the abdomen, and that's a sign of retroperitoneal bleeding in the setting of pancreatic necrosis. Here on the left, we have a gray Turner sign with flank and ecchymosis at the flank area, and then Cullen sign is when there's periumbilical bruising, and this is from retroperitoneal bleeding. A fascinating physical exam finding, which you rarely see, is actually pancreatic paniculitis. This is a rare complication, maybe 2 to 3% in patients. Unclear etiology, but thought possibly from release of pancreatic enzymes entering fat globules due to increased permeability of the microcirculation within the lymphatic vessels. Moving on to laboratory findings, lipase has a sensitivity of 82 to 100%. It rises within 4 to 8 hours and peaks at 24 hours. Can also be elevated, important note, it's cleared by the kidney, so renal failure, bowel obstruction, diabetes, DKA, HIV. It's also important that, if a patient's had an ERCP and they have no clinical signs of pancreatitis, but a lipase is checked routinely, can be 25% of the time or so elevated. It doesn't mean they had pancreatitis. It just can be related to the manipulation in the area. Other findings which may be seen, laboratory findings, elevations in inflammatory markers, leukocytosis, elevated hematocrit suggesting hemoconcentration, as well as an elevated BUN. Hypocalcemia can be seen. This is due to precipitation of calcium salts in abdominal cavity, and lower calcium does portend a worse outcome in patients with acute pancreatitis. In terms of the causes of acute pancreatitis, really the vast majority of the time it's gallstones and alcohol. You can have hypertriglycerides as well, genetic causes, autoimmune causes, trauma, infection, surgical complication. But as an inpatient, most of the time what we're seeing is gallstones and alcohol. Some of the workup of acute recurrent pancreatitis of unclear etiology is done in the outpatient setting. And we'll get into some of those special workup for those patients. Gallstones and microlithiasis account for 40 to 70% of acute pancreatitis. The thought is if there's two sort of hypotheses. One is that if there's reflux of bile into the pancreatic duct, that can lead to edema of the ampulla from obstructing stone and sludge. Stones less than 5 millimeters are most likely to pass through the cystic duct and thus most likely to actually cause acute pancreatitis. Alcohol accounts for 25 to 35% of acute pancreatitis. It develops in about 10% of patients with chronic alcohol use disorder. Typically, this is patients who have greater than 5 years of ongoing substantial alcohol use. The mechanism is unclear, but there is some thinking that possibly alcohol leads to increased viscosity of pancreatic secretions, which leads to progressive inflammation, fibrosis, and obstruction of small ducts. Okay, moving on to workup of acute pancreatitis. The history, we should ask all our patients about prior symptoms of gallstone disease, biliary colic, the amount and pattern of alcohol use, medication history, if there's a personal history of hypertriglyceridemia or hypercalcemia, weight loss and new onset diabetes. Those are concerning and potentially in an older patient for a pancreatic malignancy. If there's a history of autoimmune disease, or if there's a family history of pancreatic cancer, raising suspicion for potentially pancreatic mass, or if there's a family history of pancreatitis, raising concern for hereditary pancreatitis. Routine tests, we should obtain liver function tests, abdominal ultrasound to look for gallstones or sludge in the gallbladder. Calcium levels, hypercalcemia can be a rare etiology of pancreatitis, and hypocalcemia, again, can be seen in the setting of acute pancreatitis. Triglyceride levels, if they're really, really high, greater than 1,000, can be considered the underlying etiology of acute pancreatitis. And that's important to know as the management of hypertriglyceridemia related pancreatitis is quite distinct. What about selected tests and studies in certain patients? If there's a patient, this is often done as an outpatient, but if there's a patient who's less than 35, has a family history of acute pancreatitis, no gallstones, no history of significant alcohol use, we should consider genetic testing. In those patients with an unclear etiology, and particularly in a first attack in an older patient, we should perform an endoscopic ultrasound. Those are to look for small ampullary tumors, microlithiasis, a small a mass in the pancreas leading to obstruction, particularly small neuroendocrine tumors, or early changes of chronic pancreatitis. Typically, we do this after the acute inflammation has resolved to help resolution of our study in around 4 to 6 weeks. I included this slide because you will be asked about hereditary pancreatitis on your board exams. There are 3 main genes we need to be aware of. PRES1, it is autosomal dominant. This encodes cationic trypsin, so it's a catalyst for the conversion of pancreatic zymogens into pancreatic digestive enzymes, and it just leads to early activation of these enzymes. So PRES1, again, autosomal dominant. SPINK1 is autosomal recessive and actually has complex genetics, and this encodes a pancreatic trypsin inhibitor, and so mutations lead to decreased protective action. CFTR, there's multiple genetic variants, and it may cause pancreatitis due to increased viscosity of pancreatic juices with or without associated manifestations of pulmonary CF. Now we'll discuss a little bit more detail on the classification of acute pancreatitis. In 2012, there was revision of the Atlanta classification and definitions by international consensus. This really helped standardize how we classify pancreatitis. And the reason this matters is certain classifications have worse or better outcomes. The vast majority of acute pancreatitis is interstitial edematous pancreatitis. About 15% of the time, however, patients can develop necrotizing pancreatitis. Interstitial edematous pancreatitis on a CT scan with IV contrast, you will see enhancement of the whole gland. There'll be no areas of hypoenhancement. You may see edema, you may see some free fluid and inflammation, but again, the gland enhances nicely throughout. By contrast, in necrotizing pancreatitis, you see lack of parenchymal enhancement, either of the pancreas or peripancreatic fat. This is a gross specimen of necrotizing pancreatitis where you see necrosis and hemorrhage. The reason this classification matters is the mortality is quite different between the two. So in acute interstitial edematous pancreatitis, mortality is less than 5%. In those with affected necrotizing pancreatitis, the mortality can be up to 30%. It's still even quite high in those with sterile necrotizing pancreatitis, up to 20% in some series. We further classify pancreatitis into mild, moderately severe, or severe. And the distinction here is organ failure. If there's severe persistent organ failure, it's severe acute pancreatitis. Mild, no organ failure, and moderately severe is when there's transient organ failure or if there's a local or systemic complication. What are some of these local or systemic complications? Systemic inflammatory response syndrome, exacerbation of pre-existing conditions, organ failure. In terms of what in the acute phase of pancreatitis, there's a ramped up immune response, and it's really what leads to morbidity and mortality is an overwhelming systemic and inflammatory response. After about 2 weeks, there's an attenuation of the immune response. And if there's necrotizing pancreatitis, that's when you start seeing the transition to infection, and that's when infection starts to become a problem. In terms of local complications, you can have gastric outlet obstruction, portal or splenic thromboses, colonic necrosis, pancreatic or peripancreatic collections, which we'll further classify. Again, this classification matters because we think about some of the it helps us determine the localized complications of acute pancreatitis. Those with interstitial edematous pancreatitis may develop an acute peripancreatic fluid collection. That is a homogeneous fluid adjacent to pancreas without a recognized wall. After about 4 weeks, typically, it's not perfect, but around that time, we start seeing this fluid organize into an encapsulated, well-defined extrapancreatic fluid collection. This is a pseudocyst with minimal solids. In terms of necrotizing pancreatitis, initially we can have an acute necrotic collection with extra pancreatic necrotic collection without a defined wall. Around the 4-week mark, your body starts to wall this off, and that's when you developed walled off necrosis. And by contrast to a pseudocyst, this has solid components as well. Terms we shouldn't use, and we sometimes still see them in reports and imaging studies, or phlegmon, pancreatic abscess, or hemorrhagic pancreatitis. We should really be using this classification system. I think I mentioned already, alluded to the complications of acute pancreatitis. Really early, it's organ failure, and late, we have to worry about infection. What about the clinical predictors of severity? There's lots of complex scoring systems, but really it's been shown that using a SIRS response or looking at these predictors are much easier at the bedside. So advanced age, severe coexisting conditions, if there's long-term heavy alcohol use or a high BMI. The bedside, if you're going to use one scoring system, the bedside index for severity of acute pancreatitis is quite easy. BUN greater than 25, impaired mental status SIRS, age greater than 60, or pleural effusions. With each point, there's a higher rate of hospital mortality. If you get all 5 points, you have up to 22%. Okay, hopefully we can spend the majority of our time discussing the management of acute pancreatitis. There's a variety of guidelines. There's been some updates in AGA and ACG in the last couple years. APA and IPA have also had some, have a good guideline. It hasn't been updated in a while. There's also some European and surgical guidelines. I think it's nice to look at both the GI and the surgical literature on this, although now they're all reaching a consensus and very similar themes among all these guidelines. And the key points that are emphasized now are using this revised terminology, so making sure we're classifying acute pancreatitis correctly, recognition of predicted severe pancreatitis, understanding the increased mortality here, the importance of enteral nutrition. That is a key point in these patients. The importance of performing a cholecystectomy in patients with biliary pancreatitis, and fluids, a goal-directed, moderately aggressive intravenous hydration approach. What's de-emphasized, prophylactic antibiotics, early CT scan, surgery, particularly open necrosectomy in these patients. We'll go through each of these in further detail. So in terms of fluid resuscitation, why does it matter? Well, it maintains perfusion of the pancreatic microcirculation and intestine. It prevents intestinal ischemia and subsequent bacterial translocation. It's been shown to improve clinical outcomes. Now, what about the type of fluid or the rate of resuscitation? So back in 2011, there was a study that showed early fluid resuscitation reduces morbidity among patients with acute pancreatitis, looking at sort of early aggressive fluids and looking at organ failure and SIRS. There was also a study around this time that looked at lactated ringers compared to normal saline and found an improvement in outcomes with lactated ringers. It is important to note that those patients who have pancreatitis related to hypercalcemia, you should not use lactated ringers. There was a great study from a former UCSF fellow, Dr. Buxbaum, down at USC, that looked at early aggressive hydration with a 20 ml per kg bolus followed by 3 mL per kg per hour to see if that could hasten the clinical improvement in mild acute pancreatitis, key mild acute pancreatitis. And this did show an improvement. The biggest study we've seen with regard to fluids in acute pancreatitis, known as the Waterfall trial, published in New England Journal back in 2022. And this was looking at aggressive or moderate fluid resuscitation in acute pancreatitis. The thought was, if we give aggressive fluids up front, can we reduce the chance of a patient develop severe acute pancreatitis and improve outcomes? It was a multi-center, open-label, randomized control trial, and patients with mild acute pancreatitis were randomized to either, on presentation, aggressive fluid, so that's a 20 ml per kg bolus followed by 3 mL per kg, or a moderate fluid bolus. So that would be if there were clinical signs of hypovolemia, they would do a 10 ml per kg bolus followed by 1.5 ml per kg infusion. And the primary outcome was development of moderately severe or severe pancreatitis. What was found is doing this aggressive report actually didn't change the development of moderately severe or severe acute pancreatitis or hospitalization, but it did increase the risk of fluid overload. It did not improve organ failure or any local complication, which were their secondary outcomes. So the conclusion from this study was, among patients with acute pancreatitis, early aggressive fluid resuscitation did not lead to a lower risk of moderately severe or severe acute pancreatitis than moderate fluid resuscitation, and was associated with an increased risk of fluid overload. So really it's the balance of preventing renal failure, necrosis, and infection, but also not overloading the patient and leading to hypervolemia. So what's the approach in 2025? And this is the recommendations also in some of the newer guidelines, really a controlled fluid expansion with lactated ringers in the first 40 hours. So 1.5 ml per kg per hour with a 10 milliliter per kg bolus in patients with hypovolemia. And really, once you start those fluids, you shouldn't let them run without reassessing the patient. So while there's some studies that show goal-directed doesn't improve outcomes, I think it makes sense, and these guidelines do recommend keeping an eye on clinical parameters to see if your fluids are working, and also not overloading the patient. You don't want to just blast these patients with fluid and not checking on them. What about pain control? Acute pancreatitis is very painful, and uncontrolled pain can contribute to hemodynamic instability. Opioids are safe and effective, and patients often need high doses in the acute setting. Typically, we give hydromorphone or fentanyl. There is a theoretical risk that morphine can increase sphincter of Oddi dysfunction pressure and potentially worsen the pain. Typically, we use hydromorphone or fentanyl. What about early CT scan? Well, the challenging thing here is most patients, by the time they reach the floor, have already been scanned in the emergency room. But that being said, for those patients who have it, it's important to remember that if you get a CT scan right when someone comes in, the sensitivity for the detection of necrosis isn't great. And it doesn't really change the early phase of clinical management. As you can see in these two images on below, on admission, the pancreas may look not that bad, just a little bit inflamed with a little bit of peripancreatic fluid. And then a week later, you can actually see development of necrosis. So early CT scan isn't great for figuring out exactly what the course is going to be. What about antibiotics? Well, we really need to be mindful of infection, in particular those with necrotizing pancreatitis. There's no evidence to suggest that prophylactic antibiotics can prevent infectious complications in acute pancreatitis. In terms of nutritional support, it depends on the severity. In mild acute pancreatitis, the trial of PO can be initiated early within 24 hours, as long if the pain is decreasing and there's an absence of ileus, nausea, or vomiting. Typically, even we do this in terms of slow, cautious advancement of diet, but there is evidence to suggest that early refeeding with a low-fat diet in patients with mild acute pancreatitis is safe and is not surprisingly associated with a decreased length of stay rather than slowly ramping up from liquids to a low-fat diet. In those patients with moderately severe to severe pancreatitis, oral feeding may not be tolerated due to pain, nausea, vomiting, or gastroduodenal inflammation. In such patients, if oral diet cannot be tolerated, we really need to start thinking about NG or NJ tube to give them tube feeds. There was a study published back in the New England Journal in 2014 that did look if you give early nasoenteric tube feeding, basically within 24 hours, compared to waiting a couple days if they can't tolerate, do you change the outcome and predict severe? And really, you don't. So the thought is, give them a little bit of time, but if they're not tolerating PO within 3 to 5 days, that's when you start thinking about tube feeds. The key here is that we really want to do enteral therapy. We don't want to just keep a patient MPO and put them on TPN. Why is that? Well, there are very few things actually that have improved survival in the management of acute pancreatitis, and enteral nutrition is one of those. So with enteral nutrition, we have decreased infection, decreased organ failure, decreased surgical intervention, and importantly, decreased mortality. The only, when should we think about TPN? Really, if the target rate isn't achieved, but we should really, really do our very, very best to give these patients enteral therapy, and early nutritional support is critical. Multiple meta-analyses have shown improved mortality, infectious complications, and multi-organ failure, and the need for surgery. What about the role of ERCP in acute biliary pancreatitis? There used to be a thought that if you did an early ERCP with sphincterotomy, you may alleviate some pressure. If the pathophysiology is related to an obstruction there, you may improve the outcome. However, that has been shown not to be the case in a randomized control trial that was published in the Lancet. So really, the ERCP should be utilized only if there's coexisting cholangitis or ongoing biliary obstruction, such as an impacted stone. This is just the paper that was looked at and published by the Dutch Pancreatitis Group. They basically support a conservative strategy in patients with predicted severe acute gallstone pancreatitis. So ERCP only if cholangitis or ongoing biliary obstruction. There's no really role for an early ERCP to improve any outcomes in the absence of cholangitis or biliary obstruction. If it's unclear if there's a stone, MRCP or EUS is very helpful and non-invasive. It is important to remember that EUS is superior to MRCP for detecting small stones in the bile duct, and often it is these small stones that are most likely the culprits in biliary pancreatitis. What about cholecystectomy during biliary pancreatitis? For those with mild acute pancreatitis, as they recover, we recommend performing cholecystectomy during the same hospitalization. This has made it to many guidelines, and the reason is failure to perform a cholecystectomy is associated with a 25 to 30% of recurrent acute pancreatitis, cholecystitis, or cholangitis in a fairly short interval of 6 to 18 weeks. There's been meta-analysis here that look at early versus delayed cholecystectomy for mild acute gallstone pancreatitis. And essentially doing a cholecystectomy earlier, as long as they're recovering, is associated with improved outcomes. It can reduce biliary complications in mild gallstone pancreatitis. It's a little more challenging in what to do in the timing of patients with necrotizing pancreatitis. When should we perform a cholecystectomy? This is a nice paper. Again, the Dutch are sort of the leaders in the literature of necrotizing pancreatitis. What they found in this study was the risk of overall recurrent biliary events prior to cholecystectomy was significantly lower before 10 weeks after discharge, and the risk of recurrent pancreatitis before cholecystectomy was significantly lower before 8 weeks after discharge. And the complication rate of cholecystectomy did not decrease over time. It's important to note that in this study, they showed that endoscopic sphincterotomy did not reduce the risk of recurrent biliary events. We are often asked to do a sphincterotomy to reduce the risk of recurrent biliary events, but there's a lot of literature to suggest that this isn't super helpful. We do need to be mindful, though, of patients with necrotizing pancreatitis and local and systemic complications before we embark on surgery. This is a nice algorithm. So if there's necrotizing acute biliary pancreatitis with collections, at discharge, we perform imaging. If the collections are gone, then we reevaluate 3 to 4 weeks. And if the collections are gone, then we perform a cholecystectomy. That's fine. Now, if those collections are still there, we reevaluate in a few weeks. And if there's persistent collections, we keep evaluating these collections until they resolve, or if there is a large collection that maybe we have a discussion about draining this collection to allow for surgery. There are some patients who have persistent collections that are small, and it's really a discussion with a surgeon about the risks and benefits of performing cholecystectomy. In those patients with alcohol-related acute pancreatitis, it's make sure that you're not missing biliary pancreatitis. You may find that someone drinks but not excessive amount, and you don't want to miss another common cause of pancreatitis. Now, if it's pretty clear that it's alcohol-related, it's helpful to have a brief alcohol intervention during admission with an addiction specialist to talk about changing lifestyle. In those with triglyceride-induced pancreatitis, plasmapheresis until triglycerides are less than 500, or insulin if plasmapheresis is not tolerated or available. About 25% of the time, we can have idiopathic pancreatitis. And as we discussed, in those patients, if it's not clear they've recovered, we should discuss EUS as an outpatient to look for microlithiasis or an occult neoplasm. If EUS is negative, a secretin-enhanced MRCP, which allows to see how the duct flows, can help with looking at other rare morphologic abnormalities, although EUS is quite good. If there's no cause found after the second attack, then genetic counseling is recommended. This is a prospective randomized multi-center trial looking at can laparoscopic cholecystectomy prevent recurrent idiopathic acute pancreatitis, with the thought, is there a subset of patients who have microlithiasis, and it's not really idiopathic, but there's an issue with the gallbladder. What's interesting here is that in those with 2 or more attacks of pancreatitis, unclear etiology, and a workup, the number needed to treat is 5 in reducing and preventing recurrent acute pancreatitis. So this is, always remember, if you've had a couple attacks of pancreatitis, you've had extensive workup, EUS, negative genetic testing, referring to a surgeon for laparoscopic cholecystectomy is something we should consider in these patients. Number needed to treat of 5 is quite impressive. Briefly, I'd like to discuss the post-ERCP pancreatitis. The main thing here is avoid unnecessary ERCP, as I discussed in my last talk. Really, ERCPs should be only performed with a therapeutic intent and really with strong indication. The risk factors, patient-related risk factors, are those biggest risk factors: a history of post-ERCP pancreatitis, young age, female. Procedure-related is challenging cannulation, balloon dilation of the orifice, multiple wire or injections. In terms of what we can do procedurally, rectal nemethicin, and especially the rectal nemethicin in combination with the prophylactic pancreatic duct stent, can significantly reduce the risk of post-ERCP pancreatitis. It also has been shown that aggressive fluids in the periprocedural time can reduce post-ERCP pancreatitis. Let's see here, how am I doing in time? Okay, there's lots of time. So I'd like to focus on necrotizing pancreatitis a little bit more here. And the reason, again, is these patients can get quite sick and have a significant mortality in the hospital. In terms of the main topics to think about with necrotizing pancreatitis, it's the indications for intervention, timing of intervention, optimal approaches, and some of the complications of necrotizing pancreatitis. When do we intervene in patients with necrotizing pancreatitis? If they're suspected or documented infected necrotizing pancreatitis with deterioration, ongoing organ failure for several weeks after the onset of pancreatitis, if there's sterile necrosis and the collection is walled off and leading to significant compression of important structures, biliary obstruction, or persistent iron wellness, we can consider drainage or intervention here. And if there's a full pancreatic duct transection, disconnected pancreatic duct, that's a time to consider intervention. Again, the key point is to consider. So how do we know sterile versus infected necrosis? We may see gas in the necrotic collection. That doesn't always mean there's an infection. It can be that the collection is fistulizing into the bowel and sort of finding a way to drain itself. There used to be, CT guided fine needle aspiration or EUS guided fine needle aspiration. There's a false negative rate, and because especially if you're doing EUS guided, you're puncturing through the bowel, you can have GI contaminant as well. So it's not perfect. Really, I would say it's a clinical suspicion. So abrupt change in status, sepsis, particularly if you on that 2 week mark, there's persistent organ failure. If you have that and you have a scan that has some air in the collection, then we really have to be mindful and act quickly in these patients. The good news is that the first thing to do is start antibiotics, and particularly with pancreatic penetration. Penims are great in this situation. In terms of the timing of intervention from a procedural perspective, really, you want to delay as much as possible to allow an acute necrotic collection to become organized or form walled off necrosis. Now, you can't always do that, and we'll get into some discussion about what you can do in that situation. So generally, wait 4 weeks or longer if possible. The key point here is, we'll discuss a bit more detail, is early open surgical intervention is associated with work outcomes, morbidity and mortality, and really shouldn't be performed except in the rarest of circumstances. Minimally invasive interventions for complications can be considered, such as compartment syndrome or spontaneous bleeding if possible. The key is minimally invasive. Multidisciplinary management is key. We need to work closely with our colleagues in ICU, our surgical colleagues, and our IR colleagues. We have a menu of options here, supportive care in the ICU and antibiotics. There are surgical approaches, percutaneous and endoscopic approaches. And we'll get into really the key here is a step-up approach, starting with the least invasive options and working your way to more aggressive options. What do we do in percutaneous catheter drainage? In the retroperitoneal space, our interventions, our colleagues in interventional radiology can place a percutaneous drain. This can be done in the early setting if needed to help decompress an infected acute necrotic collection, or later after something has become walled off. This allows for a flushing. It can also allow us to perform, surgeons to go through this track if needed, which again is unlikely. And the key point here is that many patients actually just need a percutaneous drain alone, and symptoms and collections resolve here and don't need further. The issues here is that there can be complications, particularly a pancreatic cutaneous fistula can develop here. Okay, so again, the benefits of percutaneous drainage: it can drain pus and fluid, reducing systemic manifestations of sepsis. It can avoid or delay further interventions. It can be an access for minimally invasive surgery or video-assisted retroperitoneal debridement. It can be an adjunct to endoscopic therapy. Sometimes collections really extend low, deep into the pericolic gutters and are not accessible by endoscopic drainage. And again, it may preclude the need for any further interventions. What about endoscopic approaches? We're able to perform endoscopic transluminal drainage from inside the stomach or small intestine. We can target the collection and perform a cystgastroscopy with the lumen-imposing metal stent, and that serves as a window for us to perform endoscopic transluminal necrosectomy. There's been quite an evolution of endoscopic therapy. We started with pigtail stents and performing multi-stage procedures. We used covered metal stents from that we use in the biliary system. And then what's really revolutionized our approach here is the development of the lumen-imposing metal stent, or axio stent, which allows us large diameter to drain pus and also serve as a gateway to actually place our scope into the collection and debride this necrotic material. I want to show a quick video of what we do. It's not, just takes a lot of elbow grease in patients. We use off-the-shelf endoscopic tools such as snares to enter the necrotic collection and slowly grab these and pull out these necrotic debris. We can lavage as well during this period. There's some providers starting to use what's called the endorouter to help facilitate endoscopic necrosectomy, but most of us are using a snare most of the time. Then you can start seeing healthy back wall there. That back wall is quite vascular, so you need to be mindful of large vessels that are running through. But you just slow and steady work your way to try to clean out the collection. Often takes multiple sessions, up to 4 or 5. Is sort of this typical in a large necrotic collection. And there's a nice healthy back wall. So another approach, is if you have a large catheter percutaneous drain up to 24 French, if things aren't getting better and for some reason there's not a good approach endoscopically here, there is a role for surgery, but just like any development or intervention here, it's a minimally invasive approach. Never jump straight to an open necrosectomy. And very rarely do patients actually ever need surgery. But if you're going to do surgery, a video-assisted retroperitoneal debridement, going through a small track and cleaning out this way is the ideal way to start. In terms of open surgery, it's rarely performed. It's always there in those very rare patients, but it really, given the high morbidity and mortality, should not be the first approach and should only be done in the most extreme setting. The reason: there can be lots of long-term complications, pancreatic fluid leakage, incisional hernias, and a very high mortality rate in open necrosectomy. So the real approach here has been studied. We have multiple randomized control trials, very high quality evidence to look at what's the best approach here. Do we do an open approach or a minimally invasive type of approach? Some of the first studies published in the New England Journal in 2010 looked at an open surgical necrosectomy versus a minimally invasive type of approach. Now, this first study did not look at endoscopic treatment, but started with percutaneous drain and then a second drain, and then if needed, a video-assisted retroperitoneal, so minimally invasive approach, not an open necrosectomy. And basically, the composite endpoint of major complications or death, the major complication of organ failure, or hernia is all reduced, favoring a minimally invasive step-up approach. Better overall in basically every category that matters. So now we have multiple other and randomized controlled trials. The Penguin study looked at surgery versus endoscopy. Surgery had a much higher rate of morbidity. Endoscopy is, for example, enteric fistula 50% versus 0. The tension trial looked at percutaneous versus surgery versus endoscopy. Complications were lower, non-significant in terms of mortality in this study, but complications were lower, length of stay was lower, cost is lower in the endoscopic group. Surgery versus endoscopy in the Miser study, basically a composite was much less than endoscopy versus surgery. Pancreatic fistula was 0 compared to 28% at a lower cost. The Panther study was a sort of longer-term study looking at the step-up approach, and the composite endpoint of death or major complications was significant, 44% for 73%. So really the key here is a minimally invasive step-up approach for patients with necrotizing pancreatitis if intervention is needed. This was a really cool study that was again published by the Dutch Pancreatitis Group in 2021. The thought was, in those with infected necrotizing pancreatitis, if you intervene right away, do you change the outcome? But their intervention was a percutaneous drain within 24 hours versus monitoring the clinical course, starting antibiotics, and performing interventions only if needed. So these were 104 patients with infected necrosis, and they were randomized to immediate drainage with antibiotics or administration of antibiotics with non-operative drainage postponed until the development of walled-off pancreatic necrosis. And what they found is really no difference in immediate versus postponed drainage. There was, in patients who went immediate drainage, they were more likely to undergo necrosectomy compared to postponed drainage. And this, I think, is really the meat of the study here. So at 6 months, the mean comprehensive complication index score did not differ significantly between the groups. The immediate drainage group underwent more interventions, more catheter drainage, more necrosectomies. And I thought was really interesting here is that almost 40% of the postponed drainage group, so those are patients with just antibiotics, actually did not require any intervention. So really you want to delay if possible. And many of these patients will improve with no intervention at all, just antibiotics. So to summarize, the approach should be maximal supportive therapy, delay intervention if possible, if you need to perfect a necrosis. If there's a non-encapsulated collection, that's when we think about, or distance very far away from the stomach or duodenum, such as pericolic gutters. That's when we think about a retroperitoneal approach with our interventional radiology colleagues. If there is a encapsulated walled-off collection that's close to the stomach or duodenum without deep extension, or even with some deep extension, we've actually been able to drive our scope pretty far in some of these patients down. We think about endoscopic transmural drainage and necrosectomy. If there's both, deep collections, deep extension down the pericolic gutters, and very large collections abutting the stomach and duodenum, we think about multimodal percutaneous and endoscopic treatment here. And really, only if these failure with these minimally invasive IR and endoscopic treatments do we consider stepping up to a surgical approach. And again, if there is a surgical approach, the first one to step up to is going to be a minimally invasive video retro-assisted debridement, not an open necrosectomy. So it's really important that we work closely with our colleagues, try to talk directly with the services, the attending surgeons, the attending interventional radiologists. Every case is can be a little different, but we have to be mindful and work closely and do our very best. And not, sometimes we have the urge to do something right away and it may not be in the best interest of the patient. I only have about 10 minutes, so I do want to just take a couple minutes. I know it's a lot of information to talk about disconnected pancreatic duct syndrome. I won't go into too much detail here, but I just want you to be aware of this. This is in those patients, particularly with up to half of patients with necrotizing pancreatitis. There's a complete, not just a leak of the pancreatic duct, but a complete disruption of the main pancreatic duct. And that recreates an orphan gland pancreatic tissue upstream. And why we need to be cognizant of this is that it can lead to persistent pancreatic fistula, as you have an orphan gland that is still producing pancreatic enzymes that lead to continued fluid collections. CT scan or MR can be helpful. MRCP can be helpful. The sort of gold standard is ERCP, though often an MRCP or CT scan is usually is first performed and often can be found. The main thing is that some patients are asymptomatic, but if you're symptomatic, these patients often, they do well after they respond to their treatment with of necrotizing pancreatitis, but then after they continue to develop this leakage or collection, and they have a persistent pancreatic fistula, or they can rarely have recurrent pancreatitis or the disconnected pancreas. The management here is ongoing, and there's ongoing discussion about what we need to do here. Some principles are, the thought is, if you are concerned about a disconnected pancreatic duct syndrome, after you've performed your necrosectomies and the necrosis is improved, if you're concerned about disconnected pancreatic duct syndrome, when you take out your lumen-opposing metal stent, you can leave a plastic double pigtail cystgastrostomy stent in place to allow for a wick for long-term internal drainage to reduce the risk of recurrent collections. That being said, many patients actually won't develop recurrent collections. Often you asked a good question. Secretin can be helpful when looking at MRCP because you'll really actually stimulate the pancreatic duct. Often, it can be seen on a regular MRC, but MRCP secretin will add some sensitivity. So this is a sort of a diagram of disconnected pancreatic duct syndrome. You see there, so initially they have necrotizing pancreatitis, often affects the neck actually. And you have this collection, you perform your treatment for debridement, this improves, but you still have this complete disruption of the pancreatic duct. And the thought here is in panel D here, if you leave a plastic stent, you can reduce sort of indefinitely, double pigtail stent, you can reduce the formation of recurrent collection. That being said, there is some, a big retrospective study that came out of India a few years ago that showed actually a majority of these patients, even with disconnected pancreatic duct syndrome, don't develop recurrent collection. So it's only a minority. We just don't know which ones. And often over time, that orphan pancreas will atrophy and sort of your body will take care of it. So ongoing area of interest, just something to be aware of as you're taking care of these patients, or if you're reconsulted, after an acute episode of necrotizing pancreatitis, and this after things have been taken out, they develop a recurrent collection. Always be mindful of a disconnected pancreatic duct syndrome. Okay, so to summarize, a lot of information here, but in acute pancreatitis, make sure we're using the correct terminology. Be mindful of those patients who develop severe pancreatitis. In terms of fluids, use lactated ringers, except if someone has hypercalcemia-induced pancreatitis, and a moderate amount with continued monitoring of the patient. Don't just overload them and not keep an eye on them. Key is enteral nutrition. Really, really use the gut, associated with better outcomes across the board, including improved mortality. In those patients with biliary pancreatitis, mild acute pancreatitis, perform their cholecystectomy before discharge. If they have necrotizing pancreatitis and no collections, perform within 8 weeks. If they have persistent collections, keep an eye on them and try to always, the thought of getting this gallbladder out as soon as you can safely, working with your surgeon closely. In those patients with necrotizing pancreatitis, delay intervention if you can. And those with infected necrosis start antibiotics. As we saw, up to 40% of those patients will respond with conservative treatment, antibiotics alone, and not need interventions. And if you're going to perform interventions, it's a step-up approach, minimally invasive, really delaying uh, um, and avoiding surgery if possible, and really, except in the rarest of circumstances, there is not a role for open necrosectomy. Okay, that was a lot of information. I think we have a couple minutes if there's any questions.